Hello everyone. Today we are going to study Chapter 3, Water and Electrolyte Metabolism Disorder and Acid-Base Imbalance. The human body metabolism is performed in a body fluid environment, and disease and changes in external environment often cause water, electrolyte, metabolism disorder and acid-base imbalance, thereby resulting in changes in body fluid volume and distributions, electrolyte concentrations, and acid-base imbalance, which, if not corrected in time, often lead to serious and even life-threatening consequences. Section 1. Overview. 1. Content and distribution of water in human body. 60% of body weight for male, and 55% of body weight for female, 80% of body weight for newborn. Intracellular fluid, 40% of body weight for male, 35% of body weight for female. Extracellular fluid includes plasma and interstitial fluid. Plasma, 5% of body weight. Interstitial fluid, 15% of body weight. 2. Main electrolyte content in body fluid. The most important cation in extracellular fluid is sodium ion, followed by potassium ion, calcium ion, magnesium ion, iodine, bicarbonate, chloride ion, organic acid, protein, and so on. Three. Osmotic pressure. The extracellular fluid and the intracellular fluid share the same osmotic pressure, the normal value of which varies between 280 and 310 mmol per liter. The stability of osmotic pressure is primary guarantee of maintaining intracellular and extracellular balance. Changes in body fluid volume and osmotic pressure will cause water and sodium metabolism disorder. It can be divided into hypotonic dehydration, hypertonic dehydration, and isotonic dehydration clinically. Section 2. Water and sodium metabolism disorder. Hypertonic dehydration, featured by decrease of extracellular fluid, low serum sodium, more sodium ion loss than water loss. Serum sodium concentration less than 135 millimol per liter, and plasma osmotic pressure less than 280 millimol per liter. 1. Etiology. 1. Loss of large amount of digestive fluid, and only water is replenished. For example, excessive vomit and long-term gastrointestinal decompression. 2. Fluid loss in third space, purinitis, and pancreatitis from a large number of anxieties. 3. Long-term continuous use of diuretics such as furosemide. 4. Water loss through skin, profuse sweating, and extensive burns. 2. Clinical manifestations. The sodium depletion is divided into 3 degrees. Number 1. Mild sodium depletion. Serum sodium 130 to 135 millimol per liter. Sodium ion depletion at 0.5 gram per kilogram. Fatigue, dizziness, numbness of limbs. Sodium ion in urine decreased. 2. Moderate sodium depletion. Serum sodium 120 to 130 millimol per liter. Serum sodium depletion at 0.5 to 0.75 gram per kilogram. Mild symptoms plus nausea, vomit, rapid pulse, unstable blood pressure, superficial venous clasps, blur of vision, standing faint, and oliguria. 3. Severe sodium depletion. Serum sodium less than 120 millimole per liter. Sodium ion depletion at 0.75 to 1.25 gram per kilogram. Annihilation. Spastic twist of muscle. Tendon reflexes diminish or disappear. Stupor, coma. Frequent shock. 3. Diagnose. The diagnosis of hypertonic dehydration can be made according to the medical history and clinical manifestations of body fluid loss. Laboratory examination. Number 1. Urocopy. Urine specific gravity less than 1.01. Sodium ion and proton in urine decreased significantly. Determination of serum sodium. Serum sodium concentration less than 135 millimole per liter. Osmotic pressure less than 280 millimole per liter. Increased. 2. Red blood cell counts, corpuscular, hemoglobin, and hematocrit increased. 4. Treatment. 1. Actively deal with the causes. 2. Supplement sodium. Sodium supplementation amount equal. Normal value of serum sodium minus measure value of serum sodium multiply body weight multiply 0.6. Multiply 0.5 in case of female. Half amount supplementation first. 1 gram sodium chloride equal 17 millimole sodium ion. 3. Types of fluid. Hypertonic and isotonic saline. 4. Complement the blood volume of patients with shock due to severe sodium depletion. 5. Supplement potassium ion and corrected acidosis. Hypertonic dehydration, featured by decrease of extracellular fluid, high serum sodium, more water loss than sodium ion loss. Serum sodium ion concentration more than 150 millimole per liter. Plasma osmotic pressure more than 210 millimole per liter. And decreased extracellular fluid and intracellular fluid. 1. Etiology. 1. Inefficient water intake. Difficulty in eating and drinking water for patients of esophagus cancer and critically ill patients. 2. Excessive water loss, such as high fever, sweating, exposed burn therapy, and diarrhea. 3. Loss of itonic or no sodium containing digestive fluid due to vomiting, diarrhea, and digestive tract drainage. 4. Excretion of large amounts of hypertonic urine through kidney due to central diabetes insipidus or nephrogenic diabetes insipidus. 5. Overbreathing due to any cause and loss of water without electrolyte through respiratory tract. 2. Clinical manifestations. Number 1. Mild dehydration. No other symptoms except thirst, and lost water accounts for 2 to 4% of body weight. 2. Moderate dehydration. Extremely thirsty, mouth parched and tongue scorched, orbit depression, poor skin elasticity, and oliguria. The water loss accounts for 4 to 6% of body weight. 3. Severe dehydration, irritability, media, hallucination, delirium, coma, and even death in addition to above symptoms. 4. Tachycardia, temperature rise, blood pressure drop, and other symptoms for severe case. 3. Diagnose. The medical history and clinical manifestations are helped to diagnose of hypertonic dehydration. Laboratory examination. 1. Urine specific, gravity increased. 2. Serum sodium concentration more than 150 millimole per liter. Plasma osmotic pressure more than 310 millimole per liter. 3. Red blood cell counts. Corpuscular, hemoglobin, and hematocrit slightly increased. 4. Treatment. 1. Actively deal with primary disease and control sodium intake. 2. Supplement water. Estimate the percentage of water loss to body weight according to clinical manifestations. If water loss accounts for 1% of body weight, supplement 400 to 500 millimeter fluid. According to serum sodium concentration, water supplementation amount equaled measured value of serum sodium minus normal value serum sodium multiply body weight multiply 4. Three. Types of fluid. 5% GS, 0.5% NS. 4. Moderately supplement electrolyte and correct acidosis. Isotonic dehydration, featured by decrease of extracellular fluid, normal serum sodium, proportional loss of water and sodium, decrease of blood volume, and normal serum sodium concentration and plasma osmotic pressure. 1. Etiology. 1. Acute loss of digestive fluid, interoctaneous fistula, massive vomit, diarrhea. 2. Body fluid loss in infected area or soft tissue, such as intrapolemia or retropolemia, infection, and intestinal obstruction. 3. Large amount of drainage hydrothermics, ascites, and extensive burns. 2. Clinical manifestations. 1. The clinical symptoms are weakness, nausea, anorexia, oliguria, but not thirsty. 2. Signs: dry tongue, albeit depression, poor skin elasticity. 3. Symptoms of insufficient blood volume, amount of loss up to 5% of body weight. Rapid palms, feeling of weight and cold on acra, unstable or decreased blood pressure. 4. Manifestations of severe shock, amount of loss up to 6 to 7% of body weight, acidosis. 3. Diagnose. 1. According to the medical history and clinical manifestations. 2. Normal serum sodium and osmotic pressure. 3. Red blood cell counts, corpuscular, hemoglobin, and hematocrit significantly increased. 4. Treatment. Number 1. It is vital to remove the etiology and easy to correct the dehydration after removal. 2. Supplement blood volume. Fluid supplement equaled percentage of lost body weight multiply body weight. Three. Type of fluid. Equilibrium liquid or isotonic saline. Today's lesson is over. See you next lesson.